Welcome to Simple Biopsy Techniques and the Best Ways to Bill for Them. This program is supported through an educational grant by Viva Learning and PRL Pharma. Educational objectives for this little talk. There are a couple. Number one, learn how to perform simple soft tissue biopsies utilizing instruments you already have in your office. No need to go out and buy anything. Everything you need to perform simple biopsies you already have. Number two, determine if a lesion is most likely benign or malignant. It would be helpful if you knew which was which, because you may not want to start working on possible malignancies. So we'll go through a little exercise to show you which lesions are most likely benign and which lesions are most likely malignant. And even if you do biopsy a lesion that ends up being malignant, there's absolutely nothing to worry about. We'll discuss that a little bit later as we go along. Number three, understand the importance of autofluorescence when determining biopsy margins. When you see a lesion and you've decided you're going to biopsy it, where do you start and end the margins? How close to the lesion, how far away from the lesion, and exactly where should the margins be? How do you know where the lesion ends and normal tissue begins? Something that autofluorescence works very, very well at giving you that information. Number four, know how to bill patients and insurance companies for oral cancer examinations and, of course, for the biopsies using autofluorescence devices. So those are the four things we're going to discuss today. First, let's learn how to perform simple soft tissue biopsies utilizing instruments you already have in your office. Once again, no need to buy anything. Everything you need for simple biopsies are already in your office. This course will give you a very simple 5-step program to perform simple soft tissue biopsies in your office without buying any new equipment. When I teach things, I like to have a cookbook. So this will be our cookbook. If you use this course just like a cookbook and just follow the 5 simple steps, you'll know what to biopsy, where in the oral cavity to biopsy, when to biopsy and when to refer, because you may not want to biopsy everything you see. Whoops, that went a little bit too fast. And of course, how to biopsy. So we'll go through all of these one by one. Step one, assess the patient. Is it a patient that you feel comfortable performing a biopsy on, or does the patient have any medical problems that may make you pause in working on that patient? Step two, assess the lesion. Is it the type of lesion that you feel comfortable treating, or is it the type of lesion that you'd rather send out to the oral surgeon? Step three, set up your tray so you have all of your instruments in front of you. Step four, do the technique as we will discuss. Step five, post-op instructions. That's it. 5 simple steps. You follow these 5 simple steps, 1, 2, 3, 4, 5. You'll be ready to run tomorrow morning and perform your first biopsy. So before we start, here's a question or two for you. Exactly what is a biopsy? And why do we biopsy? Well, the definition of biopsy, whoops, going a little bit too fast, sorry, trigger finger. The definition of biopsy is removal of a piece of tissue for microscopic examination. Why do we biopsy? To determine whether a lesion is inflammatory, systemic, or neoplastic, to determine what's causing the lesion. So we've got this patient here with terrible gingiva, hyperemic edematous. And what's the cause of that? Is it neoplastic? Is it systemic? Well, in this case, it's an inflammatory response to 2 things. Number one, the very, very poor home care. And number 2, quite possibly an allergic reaction to the metal of the braces. So this is most likely an inflammatory response. And when we remove this tissue and biopsy a little bit of it, it will come back as inflamed tissue. Systemic, Well, this is a patient that is a kidney transplant patient, a heart transplant patient, a liver transplant patient, a lung transplant patient. All of those solid organ transplant patients take cyclosporin, which is an immune suppressant that prevents the body from rejecting the organ. But one of the side effects of cyclosporin is gingival hyperplasia. Or the patient could be on dilantin, phenytoin. The patient may be a grand mal seizure patient and is taking it. Or the patient could be taking cyclosporin for any of hundreds of other diseases, alopecia, myasthenia gravis, rheumatoid arthritis that does not respond to more routine treatments. So there's plenty of patients walking out in your neighborhood that look like this. They're not going to see you. They're going to see the periodontist. They're going to see the oral surgeon to have this treated. This is something you can biopsy and you can remove on your own. And it is a very, very easy procedure. It is a very gratifying procedure, and it is a very lucrative procedure. Neoplastic. This is from the old days when AIDS was all the rage. This is Kaposi sarcoma, which of course is a vascular neoplasm that was very, very common in AIDS patients. So we biopsy to determine if the lesion is inflammatory, systemic, or neoplastic. Now, if it's malignant, we need to type it, we need to grade it, we need to stage it to determine a prognosis and a treatment plan. There's something called the TMN diagnostic criteria. That's not anything we're going to go through today, but it's something you can look at. T for Thomas, M for Mary, N for Nancy, and the TMN is a way of staging these lesions to determine the prognosis and the treatment plan. So most of you see little lesions like this on the tip of people's tongues, especially people that have calculus bridges on the linguals of the lower anterior teeth. This is nothing more than a benign irritation fibroma. Simple to biopsy, simple to remove, not a big deal at all. And we'll discuss this in a little bit more detail a little bit later on. Malignant, well, you may remember that you've got lots and lots and lots of salivary glands on the roof of your mouth. So this could be a benign salivary gland tumor. This could be a malignant salivary gland tumor. So we've got to biopsy it. We've got to find that out. There are different types of biopsies. Excisional biopsies, where you cut out the whole thing. Incisional biopsy, where you just cut out a piece of it. Oral cytology, brush biopsy, and aspiration biopsy. Oral cytology would be an oral version of, say, for example, a pap smear. Instead of a vaginal cytology, which is what a pap smear is, this would be an oral cytology. Brush biopsy and aspiration biopsy are two other types of biopsies, but we're not going to discuss those today. We're going to stick with excisional and incisional biopsies. So for the purpose of this presentation, we'll just talk about incisional and excisional techniques. In excisional biopsy, total removal of the suspect tissue. Just remove the entire lesion. So we have something going on here, some sort of oma, fibroma, lipoma, neuroma, some sort of oma, and we're just going to remove that whole thing. Incisional biopsy is partial removal of the suspect tissue. So why would you do an incisional biopsy rather than an excisional biopsy? Well, if the lesion is too large to remove easily, you may want to wait until you get the diagnosis, because if it's a large lesion and it's benign, you may not need to remove the entire lesion. Or there are multiple sites, upper left, upper right, lower right, buccal mucosa, tongue, floor of the mouth. So if there are multiple sites, you don't want to remove everything from that patient's mouth, so you sample a few areas. So this is a patient that had this hyperkeratotic lesion, and hyperkeratotic means nothing more than lots of keratin. So this hyperkeratotic lesion was throughout the maxilla, throughout the mandible, floor of the mouth. This went from the pterygomandibular raphe to the pterygomandibular raphe, all over the patient's mouth. To remove this totally, to do a total excisional biopsy on this patient would be a lot of work, and the patient would be quite uncomfortable afterwards. But if this is nothing more than a benign lesion, there would be no reason to remove it. You would just watch it. So what you would want to do is take a couple of different incisional biopsies, one from the upper left, one from the upper right, one from the lower left, one from the lower right, maybe one from the floor of the mouth, one from the palate, wherever it is. Take multiple incisional biopsies to make certain that the lesion is benign. If you take multiple biopsies, please label the bottles. So if you're taking an area from the upper right, upper left, lower right, lower left, label the bottles, because it's possible that when you do these 4 or 5 or 6 incisional biopsies, you're going to get different results. So if this is the area that we're going to perform an incisional biopsy, this area may be benign, an area on the upper right may be benign, an area on the lower right may be benign, an area on the lower left may be malignant. So you need to label the bottles so you know which specimen came from which area. Also, very important, you see the circle here. You need to label the lesion itself. You need to orient the lesion itself. The first thing you're going to do is take pictures of the lesion. And the next thing you're going to do is you're going to put sutures in the lesion so you can identify what part of the lesion is superior, what part is inferior, what part is anterior, what part is posterior. Because it is possible that in this lesion, the superior part could be benign, the anterior part could be benign, the posterior part could be benign, but the inferior part may be malignant. So if that's the case, you wouldn't want to remove all of the benign tissue necessarily. You would want to concentrate on removing the malignant tissue at a subsequent visit. So you need to orient the lesion so you know which is anterior, which is posterior, which is superior, which is inferior. So how do we do that? Very simple. First of all, as I said, take a photograph. Second thing, put sutures on the lesion. So for the superior aspect, you may put no sutures. For the inferior part, you may put 2 short sutures. For the anterior part, you may put 2 long sutures. And for the posterior part, you may put a long and a short suture. That way you know, well, if the area with no suture is benign, you know superiorly it's benign. If the part of the lesion with 2 short sutures is malignant, well, then you know that it's the inferior part of that lesion that's malignant that needs further treatment. So this is an excellent way to label the lesion so you know where exactly that incisional biopsy came from in the patient's mouth. So incisional biopsy technique. There are a couple of different ways to do this. It's preferred that you take a narrow, deep wedge. That's better than taking a wide superficial specimen, and I'll show you why in just a minute. There might be malignant tissue deep in the lesion that you'll miss if you just go superficial. So you want to take wide margins also. Very important, especially with laser biopsies, electrosurge biopsies, radiosurge biopsies, so that you don't inadvertently char or otherwise mess up the biopsy specimen. So dysplasia starts at the basement membrane. And as it grows and grows and grows, it grows from the basement membrane out into the oral cavity. If we take a wide but shallow incisional biopsy here, it's going to miss the lesion at the basement membrane. So a wide, shallow incisional biopsy is not the right technique. The correct technique would be a narrow, deep incisional biopsy. That way you get to the base of the lesion. And that's why, once again, when you do incisional biopsies, you usually do multiple incisional biopsies, so that if you did an incisional biopsy here, it may come back benign, But if you do an incisional biopsy here, it may come back malignant. So multiple incisional biopsies is the way to go. And remember, once again, when you do multiple incisional biopsies, label the bottles so you know exactly where they came from. So there are different biopsy techniques. You can use cold steel, like a scalpel. You can use electrosurgery and radiosurgery. You can use a punch, do a punch biopsy, and you can use a laser. So what's the most important determinant regarding choice of technique? And I've used all of these for biopsies. The most important determinant regarding choice of technique is one simple word. That word is training. But stop right here for a minute. Oral pathologists hate laser biopsies. They hate electrosurgery and radiosurgery biopsies. They hate all that stuff. They only want cold steel. They only want scalpels, right? That's wrong. That's 100% wrong. If you do it correctly, the oral pathologist won't even know which technique you used. So the most important determining factor as to technique, as to what you're going to use for the biopsy, is one word: training. If you are well trained in laser surgery, well trained in radiosurgery, electrosurgery training, you can perform biopsies absolutely beautifully with perfect results. The bottom line is training. So this is a pathology report from one of the first biopsies I did with a diode laser. And if you read the last sentence, marked artifactual changes secondary to laser excision are also seen. So this is a neurofibroma on the palate of a patient that I biopsied. So what does this mean, marked artifactual changes? I didn't know what I was doing. I used too much laser power, and I created some problems for the pathologist. Artifactual changes, there was too much char on the lesion. So you've got to be careful. Marked artifactual changes secondary to laser excision. Once again, this was the first laser biopsy I did with a diode. Did not have much training because this was about almost 30 years ago when there were practically no laser training courses. This is what a laser biopsy report looks like in trained hands. Multiple sections show well delineated but locally infiltrative epithelial salivary gland tumor, blah, 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 blah. And you can see there's absolutely nothing here about any artifactual changes whatsoever. So this was a perfect, beautiful laser harvested biopsy with no effect whatsoever on the tissue. The oral pathologist noted no problems at all with the tissue, with the sample, which is good because this turned out to be a carcinoma that I biopsied. Did I know it was a carcinoma beforehand? Yeah, I was pretty sure. And we'll go through how do you know if it's most likely benign or most likely malignant. Why laser? I prefer laser. Once again, use whatever you feel comfortable as long as you have the most important word behind you, training. The advantages of lasers: a bloodless field, excellent visualization of the surgical site, decreased vulnerability to post-op infection because lasers cauterize, they coagulate. More importantly, they sterilize. Though I don't like to use the word sterilize, they decontaminate, they decrease bacterial content of the area, so there's less possibility of post-op infection. There's decreased scarring because laser wounds heal with fewer myofibroblasts, so there's less scarring, less keloid, leading to no wound contracture, less post-op bleeding because of their ability to cauterize and coagulate, less post-op pain, no need for sutures or post-op meds. Laser harvested biopsies heal by secondary intent. You routinely do not suture laser biopsy areas closed unless cosmetics is of primary importance, and intraorally, cosmetics is rarely of importance. So we have to know what to biopsy. We have to know where to biopsy, critically important if you want to get paid, when to biopsy and when to refer. So what do you biopsy? You biopsy whatever looks suspicious: red lesions in the mouth, white lesions, or red and white lesions, bumps and lumps. Macules, papules, pustules, nodules. What are these four things? Macules are flat lesions. You saw before that lesions start at the basement membrane. Well, when it's a small lesion, you may not see the lesion as a swelling, but you can palpate it, you can feel it, and that would be a macule. The American Dental Association has a wonderful, wonderful video on how to perform oral cancer exams. It's available on YouTube. So if you go to YouTube and you put in American Dental Association oral cancer examination, you'll get this wonderful little YouTube presentation about how to perform oral cancer screenings and oral cancer exam. So macules are just flat lesions that you may not see because they're not raised. A papule would be a raised lesion. A pustule would be a raised lesion with pus in it. And a nodule would be a solid lesion like a fibroma, for example. So what kind of things will I see when I perform biopsies? Well, these are the top 53 oral pathologies in order of occurrence, according to the textbook Oral Maxillofacial Pathology by Neville and his co-authors. The most common thing is leukoplakia. What does leukoplakia mean? White lesion, white plaque. Leukoplakia, see that all the time, a white lesion. Doesn't mean it's cancerous. It could be just some excess keratin, could be any of 100 things. Palatal torus, second most common thing. An irritation fibroma, like I showed you earlier. Somebody has a calculus bridge on the linguals of their lower anteriors, and they get a little irritation fibroma on the tip of their tongue. Fordyce granules, little sebaceous cysts in the back of the mouth. Mandibular tori, leaf-shaped fibromas under dentures rather. Hemangiomas, ulcers, and on and on and on and on and on. There's a reason I'm going through these. Herpes, mucocele, scar tissue, angular cheilitis, smokeless tobacco keratosis, hypoplastic tonsils. The first time you see something malignant would be squamous cell carcinoma. That is the 25th most common lesion that a dentist would see, which means the first 24 most likely lesions are benign. So the odds of you seeing something malignant are not all that great. So that's good for you. You don't really have to worry about seeing something cancerous. Most of what you're going to see are just benign lesions. So that should put you at ease. We'll discuss this more in the next couple of minutes. Some more things that you may see: nicotinic stomatitis, leukoedema, shingles, lipoma, candida, and on and on and on. Okay, what do we biopsy? We biopsy lesions that don't respond to local treatment within 7 to 14 days. What that means is if you see something, you usually don't biopsy it right then and there that day. If you can figure out a reason for that lesion to be there, such as there's a lesion on somebody's cheek on the upper left, and you take a look and the buccal cusp of number 14 is broken and sharp, well, that lesion may be due to the broken cusp. So smooth down the cusp and see if the lesion goes away. Lesions that interfere with function. There's a little mucocele on your lip, and every time you eat, the mucocele gets hit and it grows bigger and bigger. Lesions that show sudden enlargement or sudden growth that interfere with things. Those are things you biopsy. Lesions that have no apparent etiology. You don't see a broken cusp, but there's a lesion there on the cheek. Lesions that are red or white or red and white. Lesions that are deviations from normal anatomy. And of course, lesions that are hyperkeratotic, too much keratin is being produced, just an overproduction of keratin. That would be a leukoplakia type lesion. So an irritation fibroma that continues to be traumatized, such as the irritation fibroma on the tip of the tongue of that patient I showed you. A hypoplastic tuberosity that interferes with chewing. Tori that are chronically traumatized because they're so large and in the way. Swellings below the normal mucosal surface. Where do we biopsy? We're dentists. Our area of expertise starts at the vermilion border and goes back towards the tonsils. So ideally, anywhere in the oral cavity, we should biopsy. Practically, though, that's not true. We'll discuss that in a minute. So you have to know where you're going to biopsy if you're going to get paid. Now, if you're entirely fee-for-service and the patient pays you, that's great. But you'd like to have the patient get some money back. So you need to make certain that what you're biopsying is something that their insurance company will pay for. If you accept assignment of insurance, as I do, you want to make sure that you're going to get paid from the insurance company for the biopsy. So we'll discuss where we should biopsy. Ideally, free gingiva, attached gingiva, tongue, palate, lip, buccal mucosa. These are all places for you to biopsy. Warning, check with dental insurance company first. Did you know the tongue and the cheek are not part of the mouth? There is one dental insurance company with which I participate. And when I do tongue biopsies like this, the insurance company will not pay me, a dentist, to do a tongue biopsy because I've been told the tongue is not part of the mouth. It is in the purview of ENTs. So this patient should be sent to an ENT for this biopsy. However, if I send this patient to an oral and maxillofacial surgeon that has the same DDS degree as me, they will get paid. Not fair, but that's the way it is with some, not all, some insurance companies. So it's always good to speak with somebody from the insurance company, get the name of the person you spoke to from the insurance company, document the date, the day, the time, so that when you send in the claim, if it's rejected, you can say, I spoke at 3 p.m. on June 7th to Tom in the Peoria office, and the conversation was tape recorded for quality control, and he said that this will be covered, and then they are obligated to pay you. Once again, doesn't happen all the time, only some insurance companies. So you've got to make certain that you're going to get paid for what you do. Buccal mucosa biopsy, very often insurance companies will pay that, not 100% of the time. Lip biopsy, very often you'll get paid, not 100% of the time. Free gingiva biopsy, there's something by number 30 there. Attached gingiva biopsy. Palatal biopsy, sometimes you get paid, sometimes you don't get paid. So free gingiva, you'll get paid. Attached gingiva, you'll get paid. Tongue, maybe, maybe not. Palate, maybe, maybe not. Lip, maybe, maybe not. Buccal mucosa, maybe, maybe not. Check with the insurance company. Once again, write down the time, the day, the date, the name of the person you spoke to. Make certain that the conversation is recorded for quality control. And that way you'll get paid. So let's go for the 5-step program. The 5-step program on how to perform a biopsy. Here we go. Step 1, assess the patient. A complete medical history can very often give you the diagnosis. It can also help you decide if this particular patient is the right patient for you to treat. Drugs used. This merits some discussion. What do you mean by drugs? Let's go through a couple of scenarios. Mr. Average Guy. Mr. Jones, before we begin the procedure, do you take any drugs? He says, no, I don't. And I ask him again, not even aspirin or Advil? Oh, sure, I take those, but those aren't drugs. I mean, I don't get a prescription for them. I do take a baby aspirin every day, and I take Advil a few times a day for my arthritis. Well, this patient could be anticoagulated, so you may not want to work on this patient. Scenario number 2, Mr. Healthy Guy. Mr. Jones, before we begin, take any drugs? No, I don't. Any supplements? No, I don't. Anything from the health food store or the drugstore? Well, sure, I take ginkgo biloba every day so I don't get Alzheimer's, and a vitamin E capsule every day. Well, ginkgo biloba and vitamin E can interfere with the clotting process, so this is a patient that may have problems clotting. Scenario number 3, Mr. Adventurous Chef. Mr. Jones, you take any drugs? No, I don't. Any supplements? No, I don't. Anything from the health food store, the drugstore? No, I don't. Keep questioning. Any hobbies? Or do you or your partner like to cook? Oh, sure. I love to cook with lots of spices like garlic, turmeric, cayenne peppers, cinnamon, and ginger. Guess what? Each one of these has anti-clotting potential. So if you have somebody that is cooking with a lot of these spices, a lot of cayenne and cinnamon and turmeric and garlic and ginger, sorry about that. You could have a patient that is anticoagulated. How about Mr. Honest Historian? Mr. Jones, before we begin the procedure, you take any drugs? Yes, I do. I take Coumadin or Eliquis or Xarelto. What was your last blood test? Do you know your INR? And he says, not sure. A few months ago, what's an INR? Most patients know their INR like they know their phone number, like they know their zip code. If they don't know their INR, this is not a patient I'm going to work on because they may have clotting problems. Scenario number 5, Mr. Honest Historian number 2, he takes Coumadin or Eliquis or Xarelto, and he just had an INR, and it was always around 2.5, give or take, and it's never higher than that. It's never lower than that. That's a patient I feel confident that I can biopsy, especially because I'm using a laser and I'll have excellent hemostasis. So always make certain that you assess the patient, make sure there won't be any problems working on that patient. Is the patient a grinder? Look at the tongue. Any signs of macroglossia? Is the patient a cheek biter? Are we going to biopsy this lesion here? Yes or no? We're not going to, because that is nothing more than a prominent linea alba in the neutral zone between the maxilla and the mandible, and the patient bites their cheek, and the linea alba sometimes gets a little bit inflamed and a little bit different looking. That's all that is. What do? I take photos of it, put the photos in the patient's chart, and reevaluate it every time they come in for a checkup. Sexual history, multiple partners, history of atypical pap smears with partners. Don't be uncomfortable discussing this thanks to HPV, human papilloma virus. Marsha Cross, the star of Desperate Housewives, Melrose Place, Quantico. She had anal cancer and her husband oropharyngeal cancer, both most likely caused by human papilloma virus. So HPV is a big deal. Human papilloma virus is a main cause of oral cancer these days. Mr. Jones, you may know that HPV, which causes cervical cancer, also can contribute to oral cancer. Have you kept up with your visits to the gynecologist? Have you had a recent pap test? Everything good? Scenario 2, Mr. Jones, you may know that HPV, which causes cervical cancer, also can contribute to oral cancer. It's important to have a discussion with your partner about pap tests. Any abnormal pap tests might be of concern with respect to oral cancer. Now, the medical history. Is that drug-induced gingival hyperplasia, or is there something else going on? This is a patient that's a kidney transplant patient. They're taking cyclosporin. So this is most likely cyclosporin-induced gingival hyperplasia. However, kidney transplant patients or transplant patients in general taking cyclosporin have a higher incidence of leukemia. This could be a leukemic gingivitis, because leukemic gingivitis can present like this. So when you see patients like this with gingival hyperplasia secondary to organ transplants and taking cyclosporin, when you remove this, it is a good idea just to sample a couple of areas, send them in for a biopsy. You may be able to spot a leukemic gingivitis before anybody else. Know the medical history. Are those aphthous ulcers? Or does the patient have Crohn's disease or Poitz-Jaeger syndrome or any of a half a dozen different GI disturbances that cause that? Is the patient an uncontrolled diabetic? They heal poorly. I don't want to get a phone call in the middle of the night from a patient that's healing poorly. Uncontrolled diabetic, going to heal poorly. I probably would not biopsy this patient. Is the patient immunocompromised? Well, immunocompromised patients don't heal as well. This is focal epithelial hyperplasia secondary to Kaposi sarcoma. So this is a malignancy, and this is an immunocompromised patient. They may not heal so well. I may decide to punt and send this to the oral surgeon. But once again, because I had a laser, I felt comfortable, and I just biopsied them and removed them. What if the patient's pregnant? We tried scaling and root planing, tried Paradex, nothing helps. and the patient's pregnant. What do? Take a photo, watch it till the second trimester. Anything special about taking photos? Of course. Always have a perio probe in the photo so you can know the size of the lesion, because you're not going to biopsy this today. This may be due to a sharp lingual cusp tip somewhere. So you take a photo of it with the perio probe in the field so you know this measures X millimeters. And then in 2 weeks, when you see the patient again, you could be standing further away from the patient, in which case the lesion will look smaller, or closer to the patient, in which case the lesion will look bigger. But if you have the perio probe in the field, you'll know exactly if that lesion has changed in size at all. And a change in size, an increase in size, is not a good thing. Warning sign. And then when the patient's pregnant, get written medical clearance faxed to your office, signed by the obstetrician or the nurse practitioner, in my opinion, not from a doula or a midwife, to perform the procedure. No epinephrine, et cetera, et cetera. Step 2, lesion assessment. You've assessed the patient. Now let's assess the lesion. The board is completely visible. Does the lesion start in the maxillary tuberosity and extend distal to the hamular notch where you can't really see it? Well, if it's not completely visible, I'm not going to do it. Can you avoid underlying anatomy? Is the lesion between 28 and 29 or between 20 and 21 near the mental nerve? I may not want to biopsy that. So you've got to know your normal anatomy. So this is just an IND I'm doing near the 28-29 area. But once again, I'm using a laser. I'm pretty confident I won't have any problem with that. So for an IND in that area, I would. Biopsy, I would probably do it as long as I know where that mental nerve is. Do you know what's normal and what's abnormal? Do we biopsy this? Yes or no? This is benign migratory glossitis, otherwise known as geographic tongue. Take pictures. Do not biopsy. Perfectly normal. Do we biopsy this? Yes or no? Wickham's striations. This is lichen planus. You can biopsy this for a definitive diagnosis. You cannot cure this. This is an autoimmune disease. You will not cure it. Do we biopsy this? Yes or no? Little yellow granules. These little yellow granules are Fordyce granules, and that you will not biopsy. Just take pictures. That's perfectly normal anatomy. Will you be able to obtain hemostasis? Exsanguination in the dental office is no fun. That's just a fancy word that says bleeding to death. Can you obtain adequate hemostasis? Is the lesion in a vascular area? Are there arterioles in the region that you need to be aware of? Kaposi sarcoma, extremely vascular lesion. You may not be able to get hemostasis with this. That's the palatal side of that initial lesion. How about this? Capillary hemangioma. Once again, using a laser, I had excellent hemostasis. Could you obtain good hemostasis biopsying a hemangioma? Maybe yes, maybe no. Vascular in the center of the palate? No, that's not vascular. That you don't have to worry about. How about vascular here? Not vascular here, but as we get closer to the teeth, you have the posterior superior alveolar arteries and veins right here. So closer to the midline, I'll biopsy. Closer to the teeth, I will probably not biopsy. Whoops, there we go. Post-op. This is a patient that had a lesion on his nose. I did not biopsy. He came to me for routine dental work after a plastic surgeon removed that. And I'm just showing this to you to show you how well lasers can be used for hemostasis. The man had been bleeding for a considerable amount of time, even though the lesion was sutures. Here's my diode laser. Here's the aiming beam of the laser right here. Got instant hemostasis. So lasers are just wonderful tools, but you need specific training to use a laser correctly. Is the lesion in a cosmetic area? Will you leave a scar? A nice little mucocele there, big mucocele. Once again, using a laser, go circumferentially around it, remove the roof, remove the little Water balloons there, leave it like that. The patient leaves like that, let it heal by secondary intent, and it heals up perfectly and beautifully. Could it be malignant? Well, fig rub. This is the mnemonic device you're going to use. Fig rub. F, fixed. The lesion is fixed to the underlying tissue. If it's fixed to the underlying tissue, it could be malignant because benign lesions are sort of rubbery and they move around. I, indurated. The lesion is firm to the touch. It's hard. G, grows quickly. Benign things grow slowly. Malignant things grow quickly. R, red. The lesion is red or red and white. Could be malignant. U, ulcerated. The lesion surface is ulcerated. Many malignancies are ulcerated. B, bleeds easily. So fig rub. More on this in just a minute. Clues that's probably benign. If it's painful, it's usually inflammatory, not malignant. The problem with cancer is that it's usually asymptomatic until it's so large that it impinges on anatomical structures, on nerves, on vascular areas. Bilateral, it's usually anatomic, not pathologic. If there's fever, it's viral or bacterial. If there are multiple lesions, it's usually viral. If the patient's been losing weight, that suggests malignancy. If you do your oral cancer screening and the lymph nodes are swollen, that suggests malignancy. If the margins are poorly demarcated, you can't tell where the lesion ends and the normal tissue begins, probably malignancy. These are reasons to refer. So when else do you refer? When fig rub turns out badly, use fig rub with a bit of common sense. This is fixed, indurated, ulcerated. 3 characteristics of a malignancy. Uh-oh. Yeah, that's nothing more than a maxillary torus with a pizza burn. So use fig rub with a little bit of intelligence and common sense. This is ulcerated, and it grew rapidly, and it's red and white. 3 characteristics of fig rub. Yeah, it's just an aptus ulcer. So once again, use fig rub with a little bit of common sense. So when do I biopsy? As soon as I see something? It depends on what you think it is. An irritation fibroma on a tongue ain't going away by itself. So something like this, you can biopsy. What else can we biopsy that's on this screen? There's one more thing, hemangioma on the lip. Simple to do. So step 3 is the tray setup. What do we need? We need a biopsy jar. Where do we get the biopsy jar? From the oral pathology lab. They send them to you for free. Gauze you have in your office, cotton rolls you have in your office, suture material of your choice you have in your office, an intraoral mirror you've got, tissue pickups, cotton pliers you have, a needle holder and scissors to cut the suture material you've got, suction tips you have, a 15 blade and a handle you have, and a denture marking stick. So you've got all of this in your office. Here it is, mouth mirror, tissue pickups. These are Adson forceps, ADSON. They work a little bit better than plain old cotton pliers. Needle holder, scissors to cut the suture material, suction tip, 15 blade and handle, suture material of choice, cotton rolls, and 2x2 gauze, and a biopsy jar that the oral pathology lab sends to you. Technique, anesthetize. Outline the lesion in your mind and then color it in. And I'll show you what I mean. That's why we use the denture marking pencils. Grab the lesion with pickups, or you can put a suture in the center of the lesion and use that to hold it. Excise the lesion, ensure hemostasis, and give post-op instructions. Block anesthesia is preferred over infiltration, because if you infiltrate too close to the lesion, the solution can distend the tissue and confound the diagnosis. If the solution is deposited irregularly, the laser, the electrosurge, the radiosurge, or the blade may cut irregularly. If you must infiltrate, inject at least a centimeter away from the lesion. So here, centimeter away, centimeter away, centimeter away, and down here, centimeter away. If you inject right around here, right around the center, you may deposit more here, a little bit more here, even more here, a little bit less here, even less here, and more here, so that the amount of liquid in the area is different, so that when you cut with whatever instrument you use, it may cut irregularly. So always either block or at least a centimeter away. Outline the lesion. Use a denture marking stick. These are the little things you use to figure out where a denture sore is. So you get these from any dental supply company, and you outline the lesion. So here's my perio probe. Take a picture. There's the lesion. I have outlined the lesion. All set. Wait a minute. How do I know where the margins are? How do I make certain that I outline the margins correctly? Simple fluorescence visualization. Early detection, fluorescence visualization, such as goggles. Goggles is a mnemonic. It stands for glasses for all cancer curing light exposed screening. Goggles, it's sold by most, if not all, of the dental supply companies. They are special lenses that are used with your curing light to detect oral cancer. This is what they look like, and they work beautifully. So once again, dysplasia begins at the basement membrane as a macule. You can't see it normally, but with the goggles and your curing light or any fluorescence visualization device, you will be able to see it. Tissue fluorescence, I'm not going to go into the whole thing about how it works. Different tissues fluoresce at different rates depending on their biological activity. Cancerous tissue is much more mitotically active. It grows more quickly, so there's a different fluorescence rate. So this would be something that is negative because the tissue is fluorescing normally. This is something that would be abnormal. We're getting different tissue fluorescence here. This would be fluorescence visualization positive. Fluorescence visualization positive here. Toluidine blue doesn't show the extent of the lesion, but the fluorescence visualization shows a much, much larger lesion than the toluidine blue did. Toluidine blue exam really missed this lesion, and it was severely dysplastic. So these things work really well. You think it's a little fibroma? Well, turned out to be carcinoma in situ, thanks to the fluorescence visualization. So this is what you do. You take your picture, you outline with the denture stick, you check with your fluorescence visualization device, your goggles, and you may end up changing your margins as a result. Original margins, and these are the margins that you're going to end up with after you use the fluorescence visualization device, such as a goggles. An oral lesion, like a cheek bite or a tongue bite that doesn't fluoresce differently, nothing to worry about. But a cheek bite or a tongue bite or some sort of lesion that fluoresces differently is something we've got to look at and evaluate. Little pharyngitis, laryngitis. Well, let's get our goggles on there. And we've got some areas that light up, and that turned out to be dysplastic. This little area here, don't really see much there, but it lights up here. This patient could possibly end up with a hemimaxillectomy. A little area that looks a little dark, that you see. Let's hit it with the goggles. There it is. And that's something that we need to evaluate further. Right there. All right, I'm interested. I've got a closet full of can't miss gadgets. How do I make money on this? There's an ADA code for oral cancer screenings using things like goggles. I hope you all know that. I hope you're all using it. Big deal. There's an ADA code. Let's see my return on investment figures. Let's say you charge $10 and you do 1,000 of these a year. So your revenue is $10,000. Cost of the unit is about $1,200, give or take. Your 1-year return on investment is $8,800. Your 2-year return on investment is $18,800. I don't know anybody that charges $10. The least amount of money I know that people charge for an oral cancer screening is $40. So at 1 year, their return on investment is over $38,000. Their 2-year return on investment is almost $79,000. Most people I'm aware of charge $75 and up. So their 1-year return on investment is over $73,000. Their 2-year return on investment is almost $149,000. Is $1,000 a year reasonable? If you work a 4-day week, not even a 5-day week, 6 patients a day have a fluorescence visualization exam. That's 24 patients a week, 96 patients a month. If you work only 10 months a year and take 2 full months of vacation, that's 960 exams. So $1,000 a year is very reasonable. With regard to the ADA code in New York City, where I practice, some Guardian policies, not all, some Guardian policies will pay up to $150 every 24 months on patients 40 years of age and over for using the goggles. Some MetLife policies, some Aetna policies, some Cigna policies pay up to $150 every 24 months, patients 40 years of age and over, to use this ADA code. I have found no Delta or Blue Cross or Anthem or other insurance companies that pay, but some of these companies, not every policy, some of these companies do. When you perform the biopsy, and you should, you get paid a nice fee for that procedure too. So a simple 2-minute oral cancer exam yields payment for the exam and payment for the biopsy, which you should be performing. Gordon Christensen's clinical report back in 2012 said fluorescence is a viable adjunct to mandatory oral cancer screening because it reveals abnormal cells before they may be noticed visually. It promotes thorough examination. It's faster and easier than oral dyes or brush biopsies. Cancer screening must be a routine part of oral exams. Clinicians should inform their patients of this valuable service. You should be doing this. You should be billing for this. You should be getting paid for this. Do these things actually work? Well, if insurance companies are paying for it, it has to have merit. How many dental insurance companies are you aware of that pay for procedures that are useless? So these things work. Critical point, JAMA, Journal of the American Medical Association, not the ADA journal, the AMA journal, January 2016, said the use of fluorescence visualization significantly reduced the rate of local recurrence in oral cancer. So these things are wonderful, wonderful devices. How do we market? Let Michael Douglas help you. This is the headline from the New York Post when Michael Douglas admitted that he was a sex addict and he had unprotected oral genital sex with a Manhattan hooker who had HPV in her genital tract, and he ended up with oropharyngeal cancer. You can find a video with Michael Douglas, and I'm only going to show you a couple of seconds. You can get this on YouTube, or you can get this from the Oral Cancer Foundation. There are lots of places to find that Michael Douglas video. We're running out of time, so I don't want to play the whole thing. And you can have that in your hygiene rooms, have the patients listen to it. You can put it in your waiting room, have the patients listen to it. And you need to talk about mammograms and sonograms and pap smears and HPV and colonoscopies and PSA, prostate-specific antigen and helical CTs and the JAMA article that I just discussed. Oh my goodness, I found something. What do? I don't want to get involved with biopsies. I could be held liable if I do it wrong or miss something. No. 4 possible outcomes. Let's go through them. It's benign and you got it all. Congratulations. Are you done? No. You recall the patient periodically to make sure it doesn't recur. Benign and you didn't get it all. Are you done? No. You recall the patient periodically, make sure it doesn't grow or recur. Malignant and you got it all. Well, congratulations, 2 thumbs up. Are you done? No. You send the patient to a head and neck surgeon. Malignant and you didn't get it all, you send the patient to a head and neck surgeon. So no matter what you do, there's no liability. The liability is that you didn't do the oral cancer screening with the goggles and the patient ends up with a problem. Post-op treatment, vitamin E or aloe vera, some people swear by them. There's no real literature that says it works great. You don't have to. Post-op instructions, post-op appointment, fill out the biopsy report for the lab. Is the specimen fully submerged in the biopsy jar? This is what you get from the biopsy lab: a jar, a requisition slip, that has your name, the patient's name, where the lesion is from, a biohazard bag. This all goes in the biohazard bag, goes into a FedEx envelope, goes right to the lab, and you get the result. Post-op appointment, examine the wound for proper healing, remove any sutures, review the pathology report. Remember, a benign report doesn't mean the job is finished. Whether it's benign or malignant, discuss it with the pathologist. If it's benign, do you remove the rest of the lesion? That's something you discuss with the pathologist. Benign idiopathic lesions can transform into malignancies. What do? You photograph it and you discuss with the pathologist. Benign, recall the patient periodically to ensure the lesion does not recur. Malignant, refer to an oral maxillofacial surgeon or a head and neck surgeon. Did you fill out the biopsy data sheet? Is the specimen totally immersed in the formalin? Did you review the post-op instructions? Insurance codes. For excisional biopsies, there are ADA codes. For incisional biopsies, there are ADA codes. For different size lesions, there are ADA codes. These are all ADA oral surgery codes, 7,000 codes. You can look them up in the ADA book. How about medical insurance? Absolutely. There are plenty of references to change the ADA codes to the medical codes. This is what you get from the oral pathologist. It gives you the ICD code and it gives you the size of the lesion. So everything you need for medical and dental is there on the pathology report. Any questions? Just ask me. Here I am, Bob Conversar. You can email me at laserbobdds@gmail.com. I use a laser. My name is Bob and I'm a DDS, laserbobdds@gmail.com. If you want to learn about other courses, we can discuss them at fullspectrumseminars.com. There are some questions. Let's get to the questions. Why no epi in pregnancy is one question. That's usually what OBs say. You need to check with the OB. Question number 2, doesn't fluorescence entail wearing the goggles and shining a curing light? Yes. When you use the goggles, you use the goggles with your curing light. Samantha, so you can do an exam and use the goggles. If there are no findings, still collect for the goggles exam code? Absolutely, positively. If you do an exam, you charge for the exam. The fact that it's a negative result is great, but you charge for it. Why is it back in the 90s there was little talk about HPV? That's a great question. The answer is HPV has really exploded. Why? Ask Dr. Ruth Westheimer, the sex doctor, or you can ask any number of people, but HPV has become epidemic these days. So HPV is highly, highly associated with oral squamous cell carcinoma or pharyngeal carcinoma. And it's something that we've got to take into consideration. So you have a 40-year-old patient that is single and goes to a cigar bar 1 or 2 nights a week and downs a couple of scotches and has a couple of cigars, and he's got multiple sexual partners. How do you know this? Because I'm like his barber. He sits in the chair and tells me way too much information. And I spot a lesion in this guy's mouth. And I have a 75-year-old patient who's been in a monogamous relationship with his wife for 50 years, doesn't smoke, doesn't drink. And I see the same exact lesion in that patient's mouth. Who am I more worried about? Much more worried about the 40-year-old. He smokes, he drinks, has multiple sexual partners, which he tells me about, which I don't really want to hear about. And there's a good possibility he has HPV-induced oral squamous cell carcinoma. So that should do it. Thank you all very much for listening. If you have other questions, you can hit me at laserbobdds@gmail.com, laserbobdds@gmail.com. Thank you very much for listening. And if anybody's got any more questions, let's see what we've got. Where do you get the goggles? You can get the goggles from most dental supply companies. Email me, I'll tell you, but usually Benco, Shine, Patterson, they usually have them. And it is 7:59, time for 1 or 2 more questions. Anybody else out there with a question? Otherwise, I guess we are done. So thank you very much. Once again, laserbobdds@gmail, Full Spectrum Seminars. will give you a list of where and when I give hands-on biopsy courses. So if you're at all interested in a hands-on biopsy technique course, by all means, email me or look up my courses, and I'll tell you where and when. Thank you for listening, and have a great evening.